Welcome to another episode from the Veterinary Research Channel. Today, we delve into a fascinating and, to our knowledge, previously unreported case in feline medicine. We will be exploring a condition known as hypoadrenocorticism, or a deficiency in the hormones produced by the adrenal glands, in a young female cat who presented with a unique set of circumstances. The adrenal glands play a crucial role in the body, producing vital hormones such as corticosteroids and mineralocorticoids. These hormones are essential for the body to respond appropriately to physiological stress and to regulate the concentrations of electrolytes, those crucial minerals in the blood. While hypoadrenocorticism is recognized in dogs, it is considered uncommon in cats, with only about 40 cases documented in the available scientific literature. In dogs, the underlying cause of this condition is often believed to be an immune-mediated process involving inflammation and the atrophy, or wasting away, of the adrenal cortex. Antibodies directed against the cells of the adrenal gland have even been detected in some dogs with primary hypoadrenocorticism. However, the reasons behind the development of hypoadrenocorticism in cats have remained largely a mystery. Previous reports have linked the condition in felines to events such as trauma in 2 instances and primary adrenal lymphoma, a type of cancer, in 3 other cases. The use of ultrasound imaging to visualize the adrenal glands in cats with primary hypoadrenocorticism has yielded limited information. In the few cases where the ultrasonographic appearance was described, the adrenal glands were typically reported as being of normal size. An exception to this was a single case where one of the adrenal glands could not even be identified. Interestingly, the combination of adrenal insufficiency alongside enlarged adrenal glands, a condition known as adrenomegaly, had only been documented in cats in the context of primary adrenal lymphoma. In canine medicine, a study examining 33 dogs with inflammation of the adrenal glands, or adrenalitis, found various types of inflammatory cells involved. The study also noted that adrenocortical atrophy was more commonly associated with inflammation characterized by lymphoplasmacytic cells rather than other types of inflammation. Notably, inflammatory adrenal disease had not been previously reported in cats. However, there was a single report in a dog describing both enlarged adrenal glands and adrenocortical necrosis, meaning cell death in the adrenal cortex, accompanied by neutrophilic inflammation on examination of adrenal cells. This particular dog was found to have hypoadrenocorticism following an adrenocorticotropic hormone stimulation test, which assesses adrenal gland function, 12 days after initially being diagnosed with hypoadrenocorticism, the opposite condition of hormone overproduction, using the same test. Treatment was not started in this dog, and it died suddenly 10 months later, with a tumor in the pituitary gland being identified upon post-mortem examination. The adrenal glands were noted to be small and scarred at that time. This brings us to the unique case we are focusing on today, an 18-month-old spayed female domestic short-haired cat, weighing 3.6 kilograms, who was brought in for evaluation due to progressive vomiting and a decreased appetite over the preceding 2 days. The owner reported that the cat had been generally healthy and was up to date on her routine veterinary care. The initial physical examination was unremarkable except for a distended abdomen. Radiographic images of the abdomen revealed linear to tubular areas of soft tissue density in the stomach, but no distinct foreign material was seen in the small intestine or colon. The rest of the abdominal organs appeared normal. Initial blood work, including a complete blood count and serum biochemistry profile, were also within normal limits. The ratio of sodium to potassium in her blood was measured at 41. The cat was hospitalized for overnight observation and received intravenous fluids and an antiemetic medication. The following day, she was anesthetized for an endoscopic procedure to remove the suspected foreign material from her stomach. She received pre-medications and was induced with propofol and maintained under anesthesia with isoflurane. During the endoscopy, several fabric hair ties were successfully removed from her stomach. Her systolic blood pressure remained within a normal range throughout the procedure. The cat was discharged later that day without any prescribed medications. However, 2 weeks later, the cat was presented again due to a worsening poor appetite, difficulty swallowing, and regurgitation. The owner stated that the cat had initially seemed well for the first few days after the endoscopy, but her appetite had steadily declined, and she was now completely anorexic. On this second presentation, the cat appeared quiet and had an elevated heart rate of 220 beats per minute. She was also observed to intermittently exhibit exaggerated swallowing. The veterinarian estimated that she was about 5% dehydrated and her mucous membranes were pale pink and felt tacky. Palpation of her abdomen was normal, and repeat abdominal radiographs were unremarkable. Point-of-care blood testing at this time revealed some significant abnormalities. She had hyponatremia, a low sodium level, at 137.1 millimoles per liter, below the normal range of 146.2 to 156.2 millimoles per liter. Her potassium level was elevated, a condition known as hyperkalemia, at 5.32 millimoles per liter, exceeding the normal range of 3.41 to 4.71 millimoles per liter. She also had ionized hypercalcemia, an increased level of ionized calcium, at 1.76 millimoles per liter, above the normal range of 1.16 to 1.35 millimoles per liter. Additionally, there was mild azotemia, indicating a buildup of waste products in the blood, with a serum creatinine concentration of 2.22 milligrams per deciliter and a blood urea nitrogen level of 51 milligrams per deciliter, both slightly above their respective normal ranges. The ratio of sodium to potassium in her blood had dropped to 26. The cat also showed signs of hemoconcentration, with a packed cell volume of 55% and a total protein concentration of 9.0 grams per deciliter. A urine sample obtained by cystocentesis had a urine-specific gravity of 1.038 and showed 1+ proteinuria, indicating the presence of protein in the urine. Based on the regurgitation and difficulty swallowing following the recent endoscopy, a suspicion of esophageal disease arose, and the cat was admitted to the hospital for treatment. She received an initial intravenous fluid bolus, and fluid therapy was continued with lactated ringer solution. Treatment with a proton pump inhibitor and an antiemetic medication was also initiated. The following day, the cat remained quiet, but her heart rate had decreased. She was observed to have intermittent muscle twitching and dilated pupils in both eyes. Her systolic blood pressure was normal at 120 millimeters of mercury. Repeat point-of-care blood testing revealed further increases in ionized hypercalcemia to 1.97 millimoles per liter. Her serum sodium concentration remained low, and her serum potassium concentration remained in the high end of the normal range. The azotemia had resolved. A complete blood count was normal but did not show a stress leukogram, which is a typical pattern of white blood cell changes seen in stressed animals. A more comprehensive serum biochemistry profile identified total hypercalcemia, a high total calcium level, at 14.6 milligrams per deciliter, significantly above the normal range of 8.2 to 11.2 milligrams per deciliter. She also had hypocholesterolemia, a low cholesterol level, and a low normal serum albumin concentration. Due to the progressive hypercalcemia, the intravenous fluids were changed to 0.9% sodium chloride solution. An abdominal ultrasound examination was then performed, which revealed that the adrenal glands were hypoechoic, meaning they appeared darker than normal on the ultrasound image, and were moderately to markedly enlarged bilaterally, with each gland measuring up to 1 centimeter in thickness. Given these abnormal findings in the adrenal glands, ultrasound-guided fine needle aspirates were taken from both glands for cytological examination. Following this procedure, an adrenocorticotropic hormone stimulation test was performed to assess the function of the adrenal glands. After collecting the post-stimulation blood sample, the cat was given dexamethasone, a corticosteroid medication. The other medications were continued. By the next morning, the cat was noticeably brighter and had started eating. The muscle twitching and dilated pupils had resolved. Point-of-care laboratory testing showed a marked improvement in her ionized serum calcium concentration, which had decreased to within the normal range at 1.39 millimoles per liter. The sodium-to-potassium ratio had also improved to 36, with the serum sodium concentration now within the normal range and the serum potassium concentration also normal. The results of the ACTH stimulation test confirmed hypoadrenocorticism, as both the pre-ACTH and post-ACTH cortisol concentrations were below the detectable limit of 0.2 milligrams per deciliter. Cytological examination of the adrenal gland aspirates was consistent with necrosis, or cell death, along with associated neutrophilic and macrophagic inflammation. Evidence of blood contamination and hemorrhage was also noted, but no signs of neoplasia or cancer were identified. Prior to her discharge from the hospital, the cat was started on prednisolone, a corticosteroid, given orally once daily, and desoxycorticosterone pivalate, a mineralocorticoid, given by intramuscular injection. After 5 days at home, the prednisolone dosage was reduced, with instructions to double the dose during times of stress. The cat returned for a follow-up examination 14 days after receiving the first dose of desoxycorticosterone pivalate. At that time, the owner reported that the cat had almost completely returned to her normal self. Her serum electrolyte concentrations were stable. Over the next 6 months, the interval between desoxycorticosterone pivalate injections had to be gradually shortened from 30 to 22 days. This adjustment was necessary because of a persistently low sodium-to-potassium ratio on the day of injection, coupled with the owner reporting lethargy in the cat for several days leading up to the scheduled injection. The owner was instructed to administer the desoxycorticosterone pivalate at home every 21 to 24 days, depending on the cat's clinical signs. The prednisolone was continued at the reduced dosage. Remarkably, the cat was doing well 14 months after the initial diagnosis with this treatment protocol. The significance of this case lies in the fact that, to the best of our knowledge, it represents the first documented instance of inflammatory adrenomegaly associated with adrenal insufficiency in a cat. The cytological findings of hemorrhage, necrosis, and neutrophilic inflammation raise questions about the primary cause of this condition. The presence of neutrophils, a type of white blood cell typically involved in response to infection or non-immune-mediated inflammation, suggests that an immune-mediated process was less likely in this case. Adrenal insufficiency resulting from acute adrenal hemorrhage and subsequent necrosis has been reported in humans during periods of increased physiological stress, characterized by elevated adrenocorticotropic hormone release and high levels of cortisol. Such stressors include recent surgery, low blood pressure, and sepsis, a severe bloodstream infection. This phenomenon has not been thoroughly investigated in veterinary patients. In this particular feline case, the anesthetic event, along with the associated brief hospitalization, was the only identifiable potential stressor. The cat was otherwise healthy before the anesthesia, which occurred 2 weeks prior to the diagnosis of hypoadrenocorticism. There was no clinical or laboratory evidence of sepsis before the anesthesia, and no anticoagulant medications were used. Importantly, the cat's blood pressure remained normal throughout the relatively short anesthetic procedure. The other reported case of acute neutrophilic adrenalitis and necrosis in an animal occurred in a dog with a functional pituitary tumor after an ACTH stimulation test was performed to diagnose hypoadrenocorticism. Furthermore, a study conducted on rats indicated that the administration of high doses of ACTH could lead to adrenal hemorrhage, apoptosis, or programmed cell death, and vacuolization, the formation of vacuoles within cells. The close temporal relationship between the anesthetic event in this cat and the subsequent diagnosis of hypoadrenocorticism raises the possibility that increased stress at the time of anesthesia might have played a role in causing the adrenal necrosis. This scenario would imply that the cat's own adrenocorticotropic hormone concentration was very high at some point. However, without a direct measurement of endogenous ACTH levels during anesthesia, this remains speculative. While the use of etomidate, an anesthetic induction agent, has been linked to a temporary decrease in cortisol synthesis in cats, this drug was not part of the anesthetic protocol used in this case. Ketamine, which was administered to this cat, has been shown to transiently inhibit the release of ACTH in fetal sheep, but this effect has not been documented in cats. Ultimately, the specific underlying cause of this cat's adrenal disease remains unclear. It is conceivable that the ingestion of an unidentified toxin or the release of a toxic substance from the breakdown of the elastic material in the hair ties could have contributed to the adrenal hemorrhage and necrosis. Emerging research on endocrine-disrupting chemicals also suggests a potential link to adrenal gland disorders. The case described here is significant as it represents only the second report of adrenal insufficiency occurring alongside bilateral adrenal enlargement and necrosis, and it is the first such case documented in a cat. This report highlights a previously unrecognized cause of hypoadrenocorticism in felines and demonstrates that the finding of large adrenal glands on ultrasound examination does not necessarily rule out a diagnosis of hypoadrenocorticism. Thank you for listening to the Veterinary Research Channel. A link for the referenced paper is in the video description. Remember to test your knowledge by answering the questions in the description, and as always, keep those minds inspired, hearts light, and tails wagging.